Good morning, and thank you for joining us for U.S. Best Practices for MENA Transformation with an emphasis on health IT today. In the interest of time, what we're going to do is give stragglers about 5 more minutes to log on, and then at that time, which will be uh, about 9:05 a.m., which will be 5 your time, we'll go ahead and get started with the presentation. Thank you, and we'll talk to you soon.
Good afternoon, everyone, and good morning, Sir Robert, and welcoming all to today's sessions. I'm Reem Matran, a health technology assessment and your expert with a background as a pediatric oncology and hematology clinical pharmacist with 8 years experience in hospital. I will be delighted to be moderating this session as a continuous collaboration with Sir Robert. This webinar series aims to bridge global expertise with the evolving healthcare landscape in Saudi Arabia, and we are fortunate to have you with us, Sir Robert. This is the third session from our collaboration as ESPOR, King Saud University. Our speaker, Sir Robert, is a US-based healthcare transformation strategist with over 15 years of experience supporting government agencies, health plan, hospital, and primary care organizations. He has worked with U.S. federal entities, including the CDC, Health Resource and Services Administration, Centers for Medicare and Medicaid Services, and military hospital within the defense of health agencies. Through the Nautical Health, he focuses on translating policy and financing design into practical implementation, improving workflows, strengthening primary care, advancing value-based models, and aligning incentives across payers and providers. His work bridges strategies and execution, helping organizations moving from reform concept to measurable system performance improvement. He currently leads cross-regional collaboration focused on adapting U.S. healthcare lessons to emerging MENA health market. Before we start, I would welcome all of you again. And I will be happy to have all the questions in the chat area. Or you can open the mics at the last 20 minutes of the session. Our session will be over 1 hour. Mr. Robert, the floor is yours. You can start now.
Thank you so much. And I'm so excited to be back. Today, we will be talking about health technology and why health technology is so critical in transforming the healthcare landscape in the MENA region. So one of the things I would like to begin the conversation is by simply sharing that one of the things that's transformed the United States healthcare system into something that is so transparent with the world is because of our innovation technology. So through population health tools and very advanced electronic health records, this has become the window for other countries to get samples of our reporting, to understand more about workflows. So without health IT, the level of communication and the sharing of information would not be possible. So we cannot have a conversation about health IT without being able to understand exactly what the importance is. So we're going to just basically end it up with that particular notion. And what I'm going to do is, as I go through some of the things that we at Nautical Health believe is really important about health IT, I'm going to invite those to open up the chat, share in the chat any ideas that you have about why health IT is so important in healthcare transformation. In general, we believe that provides a vehicle for managing the healthcare pathways as well as communicating with patients. Health IT opens the door for being more data-driven, for ensuring that you have strong care teams, to make sure that you are increasing your accountability amongst your employees, as well as it helps with protecting health information, facilitating information sharing, along with enforcing patient choice and making sure that patients are decision making, and it also helps to automate processes. And if you have any other thoughts or comments about reasons or why health IT is important, please feel free to share it in the chat box at this time. So moving on, I wanted to begin by first talking about two critical pieces of legislation in the United States that helps to build our infrastructure for health IT. The first one is the Health Insurance Portability Act, also known as HIPAA. This is what gives us the right to protect our patient information and to maintain privacy. It's so the piece of legislation that lays a foundation for a patient to have access to their medical records whenever they need it. Now, back in the days where there was no electronic health record and everything was kept in files, that was a bit more difficult to do. So when we were able to then extract data from an electronic health record or some type of healthcare data lake, it made data sharing with the patient a lot easier to do. Next, we have the Health Information Technology, Economic, and Clinical Health Act, also known as HITECH. Now, this accelerated the ability for us to promote the use of electronic health records, as well as some additional tools that were created to optimize electronic health records, such as population health tools and visualization tools that you're going to learn a little bit more about in today's discussion. Now, I would like to have an opportunity to break down health IT into major buckets so that we can really make sense of some of the things that we're seeing. It is no secret that at this point, between the integration of AI and the competition in most healthcare markets, that we get a lot of opportunities to see and experience health information technology. But I wanted to break it down into buckets so that you can understand what the primary function of each one of these buckets is. So we'll start with electronic health records, which is plainly put, is a primary source of patient information. And so inside of your electronic health record, you're going to have your problem list, your family health history, medications and visits, the CPT codes that are associated with whatever procedures the patient has had, a review of systems, referrals, and consults. Now, there are additional things that could be in the electronic record based on the particular practice, the country, and any other requirements that need to be notated. So, for example, in most states in the United States, health plans are going to require you to have minimal care gaps that are fulfilled throughout the year, such as a diabetic patient having a hemoglobin A1C done a minimum of once a year. So those things will also be integrated into the electronic health record. Some of the leading EHR in the United States, but also abroad, include Epic, eClinical Works, Oracle Health, as well as Athena Health, which is one of my absolute favorites. Now, I wanted to transition to talk a little bit about population health tools. And many individuals kind of get electronic health records and population health tools. So I wanted to make sure that I can dispel the myth today. Electronic health records is the place where you document the primary information on the patient during the clinical visit. Population health tools, on the other hand, are designed to enhance the experience for the clinicians and the health leaders. In most cases, population health tools are not available for patients. The patients will only be interacting with the electronic health record. However, population health tools do a number of things that help to functionalize the information that's in the electronic health record, including things such as the development of reports, creating additional workflows for things like chronic care management and transitional care management. They help to extend the patient information by bringing in information from a remote patient monitoring source. If there's any type of interoperability, they can pull in that information. It also helps with productivity. So if you want to create a dashboard for what things a nurse has to be done in a day or what patients a nurse needs to prioritize in a day, that's going to be able to be done inside of the population health tool. Also help with cost tracking as well as integrating other systems. So for example, if you want to pull in data from HIV if you want to connect to an AI tool that's going to help with writing out summaries for the patient chart, all of those things can be seamlessly integrated through a little tool. So some of the ones on the market that you should know about is Arcadia, Innovator, Lightbeam, and Mediquire. Also keep in mind that there are some electronic health records, for example, Oracle as well as Epic. They have population health tool extensions that you actually purchase for a different price that will do all of the services that a traditional population health tool can do. Next, we have our data migration software. Now, data migration software is very important and it's often the software that does not get the recognition. However, without it, you would not be able to transfer health information from one system to another. So some of the leading software on the market for data migration includes Airbyte and Rhapsody. Personally, I prefer Rhapsody. The majority of electronic health records and population health tools do use Rhapsody as their primary function. Their primary tool for migrating data. Some of the functions of these migration tools is that it makes it possible for you to connect to revenue cycle software, which is critical when you are pushing CPT codes from the electronic record to a database or any other type of software that can actually do billing. Next, migration tools allow for you to connect to health algorithms. And these algorithms can do things such as take large databases and determine which one of these patients may need to be prioritized for a chronic care management program, or they can do risk scaling to determine which patients are at a higher risk for being admitted to a hospital. You can connect to large databases as well as connect to point of sales if you are an organization that's doing a lot of direct sales with a patient. You'll be able to have that integrated. It also supports interoperability. So if there's any type of remote patient monitoring tool, whether that's everything from an advanced toothbrush, a Holter monitor, to an iPhone, all of that information can be integrated and moved into either a population health tool or an electronic health record through these types of migration softwares. Next, we have data repositories. Now, these are large data that house, organize, and share health information. So, if you can imagine, an electronic health record software can only hold so much information and may not be appropriate for all this information to actually live inside of an electronic health record or a population health. So you have to have a space where large mass pieces of data live. So some of the examples of that include in health information exchange. These are done to house information like admits, discharges, and transfer data that hospitals can share with both governments as well as primary care and specialty care clinics. You can also use pharmacy information or databases, any type of console from health plans that houses their billing information or any additional about the patients that the health plans themselves may collect throughout the year. Disease registries, as well as any type of shared electronic health record. So, for example, the hospital may pick, but there may be a health plan that uses a totally different electronic record. So some of that shared information may be pushed into a large data repository to limit some of the need for an individual to log into two different systems at one time to have to migrate large pieces of data into another system, which could cause a lot of server issues. Also, legacy data is really important as well. So let's just consider for a moment that a hospital system leaves Cerner and they go to use Epic. Well, the data that once lived inside of Cerner, would have to be moved into some type of data repository because all of that information would not be able to live inside of the electronic health record. An important note about data repositories is that most countries, as well as states out of the United States, have some type of government ran data repository that keeps minimal data on patients for the purposes of looking at economics related to healthcare, for looking at control, as well as making determinations about how money should be actually spent to improve healthcare transformation. Are there any questions about data repository? For all intents and purposes, a lot of data repositories are going to be very critical for individuals that are working in pharmacy because pharmacy level is usually housed in repositories and not necessarily in an electronic health record nor in a population health tool. Next is data visualization tools. So these are very critical for making sure that we are displaying that data that you are receiving in both the repositories inside of the population health tool or inside of the electronic health record in a way that healthcare professionals to actually make decisions. So currently, they're used for employee dashboards to look at their performance or their workflows. It create provider report cards to see how well providers are engaging with their patients and if patients' outcomes are actually improving. You can also use data visualization to create things like formularies, which are essential for identifying whether or not you want to put patients on something that is generic or a more expensive drug that's on the market. It's also critical for identifying patients that may be at high risk, as well as creating work lists for care pays, for engaging patients, or even for pharmacists to look at patients' charts that need to be reviewed. Are there any questions about visualization tools? In general, Tableau is used throughout the United States, regardless of electronic health record, as a primary source for data visualization. However, Google and Microsoft also have ways to visualize data, and there are a few electronic health records and population health tools that have visualization capability embedded into their software. Next is AI agents, which is a huge topic, of course, across the MENA region and across the world. AI agents are critical for help to make sure that you have some forms of automation as well as open queries that will enhance workflows. So some of the things that AI has been used for currently in healthcare includes patient communication. So a more robust way to a provider as well as to extract information from electronic health tools and pushing that data back to the patient. Developing disease pathways. It's also essential with program design as well as developing some reports, especially when you have large databases and you want to figure out ways to query that information to reports that are very useful. AI is very essential there, as well as streamlining clinical processes. So if we're going to talk about AI, I could give over 100 companies or 100 tools. But two that I wanted to just focus on to give you an example of the vast complexity of what AI can offer is Lilia, which is actually a chronic care management platform that uses AI to identify the patients that need to receive chronic care management and streamlines that process. So this is just one example of more of a patient engagement model. But then you also have AI tools like Nautical that allow healthcare professionals to go in and create their own workflows. So instead of buying into a product, you can actually buy into healthcare products that will allow you to create your workflows yourself. as we talk about health IT, one of the most conversations to have is what is essential when you're actually trying to choose the right health information technology. So I wanted to dispel the myth by share a little bit about what I advise my clients whenever they have to make the decision to buy a new product and what product to actually choose. The first one is that you have to focus on the common service you're currently providing to the patient. So sometimes it's really just about having a strong primary care visit, and it's not actually about some of the work that you may want to do in the future. Next, you want to make sure that you're maximizing your old technology first. So if you have an electronic health record working for you, we advise that you do not go and buy new software, but figure out ways to enhance it. Maybe it's about moving some of that data into a data visualization tool so you can actually see your patient outcomes and actually see your performance rather than trying to buy a new system that may be very costly. Next, I hired organizations to design their workflows prior to identifying a new technology. You want to be able to make the workflows of work patients in your organization. If you select the technology first, you may limit it in the types of workflows because then you'll be bending your workflow towards the technology. Next, consider the cost of the implementation. Above the cost of actually buying the technology, the average hospital is here from 300,000 to $1.2 million in training staff, in developing customizations, in planning workflows, and hiring of new employees to make sure that you're using the technology effectively. So you definitely want to make sure that you're considering the implementation costs, all of the implementation costs. Strong electronic health record companies and any other health tech company is going to be able to help you in scoping your project as well as doing some predictions of the overall budget. You also want to account for your staffing needs, along with making sure that you select products that can do multiple tasks. So in other words, you don't want a large product that's very expensive and only does one thing. If you're going to go out there and buy a product, you want to be able to plan for the future and for all of the different workflows instead of just buying a $1 million product that's only going to help you to jump one hurdle and then you're back on the market buying something new. Are there any questions? Okay, so moving on, I wanted to have an opportunity to talk a lot about the steps in technology adoption. Most time, people get really excited about the possibility of technology. They love the opportunity to explore the technology and to have the demos. But after that happens, you have to make sure that your employees are actually going to use the software, that the patients are going to be helped by the software, that the software is going to, the health tech company is going to give you exactly what you asked for, and that you have a true plan of action. So the next series of slides is really going to break down what these steps should look like as you're planning to adopt the technology. Now, keep in mind that millions upon billions of dollars in the United States by technology that they purchased that either never got fully implemented or never used. So the first three steps in technology adoption starts with making sure that you're whiteboarding your goals as well as planning out your project outcomes. So you need to be very clear on exactly what it is that you want and map this out even before you start to engage technology companies. That also includes diagramming your workflows that your end users are going to use. And by end users, the normal users of the software, but that is a medical receptionist, it's a nurse or a physician. We need to make sure that all of their workflows are adequately working. Next, you want to start to look and select the technology solutions that basically align with those workflows and those goals. After you begin to select the technology that you want, there's a couple other immediate next step things that you need to focus on. The first is making sure that you map your development and your implementation. So, in other words, you want to make sure that all of the processes of implementing this new technology are correctly wrote down and you have your key stakeholders at the table to sign off on each step. Next is testing and evaluation. Make sure that you have primarily a third party entity to test to make sure that this software is working effectively. A general rule of thumb is that you do not want the same company that is providing the health technology to also do the testing. Just a lot of conflict of interest in doing that. And then next, you have opportunities for your key stakeholders. That's everything from your hospital administrators to your medical directors and your end users like your nurses to have the ability to play inside this box or some type of demonstration environment so they can get used to actually what they'll be working with on a regular and consistent basis. So finally, when you've done with most of your testing and you're starting to think about go live, I wanted to break down the go live into critical steps. The first one is making sure that you develop training and you implement the training appropriately. So I have a client currently, a large that has 36 hospitals, and the training and development process takes anywhere from 3 to 6 months just to make sure that every single hospital has everything they need to train their staff effectively. So many organizations don't think about training until after the tech is actually implemented. So it's really important to think about training at every implementation of technology. Next, you have go live. That's when the system is actually up and running and individuals begin to use it. During this live stage, it's important to note that every single feature is not likely going to be used at the very beginning. So you tease out what features of this new technology you're going to roll out first. So a go live is not one day. A go live may actually take up to 2 years to unfold all of the different features that you have built with this new technology. And then finally, sustainment. So all technology gets old. All technology needs to be tested again. All technology has issues that require troubleshooting. So developing out a sustainment is very critical to ensure that organizations can keep their technology moving, that there's no disruption in operations, as well as you have the latest and greatest in any type of updates that your health technology services are offering. So, key takeaways from this conversation today. Number one is to make sure that you are choosing health IT based on the needs of your organization. Number two, take the time to plan tech adoption process, which is bigger than just a selection of the IT itself and relying on the company to do all of the work. And then finally, make sure that you're developing workflows before implementing that new technology. So I'll pause for a moment. I'll see if you have any questions, and then I know that there's also always questions and answers. Okay, so it looks like we have one question in the box that says, how can AI support public health interventions and resource allocations? And can you provide specific real world examples? That's a very good question. I'm going to break this down into bite-sized pieces so that I can answer each one effectively. So let's start off with how AI can support public health interventions. This is one of the most critical pieces of AI use. So with sources like Claude and OpenAI, what you're actually able to do with these particular tools is to develop prompts that's going to extract information from a lot of different sources, from publications to health plan data, to build out responses and program plans. These tools that can really help you to build out a public health strategy. So the Claudes, the Open Claude, the Open AI and Chat GPTs are very critical in developing out these public health plans. But one of the things to be very critical here is looking at the prompts. You want to make sure that you develop prompts that are going to specifically ask them to pull from policy, that's going to pull from research studies, pulling from national and international goals and any other type of data that's available, so that it's helping you to create a program plan that's variable and it's not limited to one type of information. The next piece of that is looking at resource allocation. I will tell you this about the resource allocation piece. This is an area where AI needs to be developed out. So any geniuses in the room that are really thinking about ways to imagine your career as a pharmacist or a health administrator in the future, it would be in resource allocation in healthcare. I will say that there are tools such as ServiceNow that are doing a good job of resource management using AI, but this is still an untapped market that I personally believe is going to be very grand, especially in the MENA region. The ministries of health are looking at ways to take large buckets of money and start to funnel them down into how it will actually be used to build healthcare infrastructure. So that's a really good opportunity. The next question asked about an attendance form. So we don't actually collect the formal attendance, but we do have software that's connected to our Zoom that takes attendance, along with working with the ISOPR to make sure that everyone gets a certificate of completion at the end of the training session. Are there any other questions? Oh, looks like we got a new one in the chat.
Mm. Okay. Can I read it for you from Dr. Bender?
Yes, yes. Thank you.
Dr. Bender, he said he's thanking you for such an insightful and engaging presentation. His first question, as healthcare becomes more dependent on AI, what future risk do you see for patient safety and data privacy? And how is HIPAA in the US being applied or adapted to address these AI-related challenges? This is the first question.
Okay, so Dr. Bender, you're spot on, and I am so excited to have a conversation about this. You are absolutely right. When AI pulls data, whether it's to help identify what critical needs a patient has, or it's developing a report, or it's suggesting the best care plan for a patient, we do not actually have a check and balance to make sure that AI is doing its job effectively. That's like biggest alarm bells that no one is really talking about right now. So we actually have Nautical Health has a contract with a health plan that is exactly what we do. With one of the health plans is that we take the data that has been developed by AI and we check it using our nurses to make sure that it's accurate. And one of the things that we're realizing is that depending on the quality measure we're looking at or workflow, sometimes AI is only about 60% accurate. So there is still a need to be clinicians, pharmacists, as well as health administrators that are in the room that are fact checking this AI information and determining why is it that this is not adequately outputted by AI. So that is a really contemporary modern topic that I think that every organization as well as every is going to have to create a health AI governance board that's going to check into these types of things and figure out what's going to be a single source of truth to make sure that this information is adequately put. I also said it's going to be really important at some point that there is some way that the governments, including the MENA region, can regulate that AI software is actually approved because they know that the accuracy is 90% or better. Currently in the market, if you have a software and people are impressed by it, they can go and buy it. But I think because it does deal with patient information and that many countries have laws that patient level information, that is our responsibility to do more in order to make sure that this is sealed and that we're protecting our patients. I will share that Nautical Health is actually developing some software that helps to fact check AI as well as other outputs from electronic records. So stay tuned. We'll be making an announcement about that at the beginning of next year. But we do see this as consultants in the implementation space of healthcare, that this is a large gap, and not enough people are having a conversation about it.
The second question is about as AI plays a bigger role in clinical decision making, what risks do you see in clinicians becoming overly reliant on it, and how can we ensure they continue to build strong knowledge, critical thinking, and professional skills? I will add also, not about all the clinician, also the patient itself. It misuse the AI tools because the information is over. It may be, we may take the risk from if we take all the information from AI, even for the patient, because sometimes they run away because they are afraid of medication safety or procedure, what can cause it. So what is the ethical and can we make a policy for these such adapting AI tools?
Absolutely. So basically, I'm going to answer this question in buckets again, but I'll just start with a high level assumption, and that is ethics are still on the table whenever we're thinking about AI. I think that somehow we believe that because AI is so quick, that we don't have to think about the ethics that are associated with it, both perspective of how the patient feels and whether or not they have a choice of if their information is going through an AI agent. So there's that. But then there's also the question about clinical decision making, and is this AI tool the source of truth when it's a doctor that actually takes an oath and a doctor that's ultimately responsible for that patient's safety? So I want to start there, and I'll kind of go a little bit deeper into the part of the question that talked about clinical decision making. I believe that from a clinical perspective, that AI is making suggestions or they're narrowing down your options. It should not be the source of truth of what the doctor should actually be delivering. And I believe there is some guardrails that should be placed where you can see passages and what the doctor actually chose to do, so that there's a check and balance or some type of data entry point where you can reconcile the two. Because I do fortunately believe that in all of the glory that AI brings, that there will be situations where if there was a poor clinical decision that was made, AI can't, but the doctor can. And for that reason, it's onus on the doctor to protect themselves. But I do believe that both at the hospital level as well as at the government level, we're going to have to give the doctors the tools to be just that, to protect themselves as well as to protect the patients. The next part of the question asked about the clinician's reliance on AI tools. And I can answer this question and the second question the same exact way. I believe that academia is going to have to play a major role. It means Dr. Bender, in all of your glory, you setting up classes and clinical grand rounds and committees that really help to create these governance boards that's going to train the next generation of students on how to be strong clinicians while using modern technology is going to be critical. So we have to groom this new set of clinicians. We also have to accept the fact that there are as many clinicians as there are that's going to be, shall I say, lazy and not want to do the work and rely on AI, that there's also resistant to this technology. So this new generation of individuals are going to be very critical into making sure that they're groomed the right way. But I also think that there is a great need for continuing education at institutions like King's University to bring top clinicians back into the classroom and to really break down some of the very elements that we're talking about today into true clinical decision making trees and workflows and helping individuals to when I need to be using AI and when is it really about my medical training.
Clear. I have a question, Sir Robert. As we know, health IT is important, but the idea behind unifying the system or adapting a new technology or even visualizing data is not easy. For the
Mm-hmm.
highly sensitive sector and from your experience in the defense, in the Ministry of Defense, and I'm also working in the Ministry of Defense, visualizing data is not easy as we think. Even if I want to visualize the dashboard, the KPI, they are not allowing this because of the sensitivity of data. Do you think
Mm-hmm.
we can find a way for visualizing even even the KPI as simple as that without visualizing the data of the patient themselves? Is there any easy way to allow this in in the Ministry of Defense or in any
Yes, yes.
other ministry? Because the
So,
security and the privacy of data and the cybersecurity is limiting everything in visualizing.
so the truth of the matter is there are ways to do it. I just think that some of these strategies are not shared as often as they should. So first is that whenever I work with any of our clients, the first thing that my team always advises is that an organization should build a data dictionary. And that data dictionary is literally going to be every single data element that is available to an organization to build a report or build any type of visualized dashboard. Once you have a data dictionary, you can then start to identify the elements of the data dictionary that are considered to be private or discrete. So, for example, patient's date of birth, their name, any type of government identifiers, those types of things should be taken out of data that's ultimately going to be uploaded into those dashboards. So that's part number one. But part number two, which I think is even more critical, is that this is where I believe every health organization needs to be working with some type of third party organization. Oftentimes, when you are trying to create your reports and you're inside the organization, you don't know what you don't know about the data. And that also means that you have blind spots in looking at your own performance or looking at your patient's outcomes. But when you collaborate with another entity, for example, Kingside University collaborating with a major private hospital inside of Riyadh, it's going to give a different perspective of exploring the data so that the organization can see some things that they probably never would have thought about their own. Lastly, I would say there are opportunities to create standardized dashboards. So inside of the United States, there is an organization known as NCQA, and they all have become a leader in data quality and making sure that patients receive the best possible care in the United States. What NCQA has done effectively is they built standardized reports that American practices should be pulling at least annually. And those are things like looking at quality gap and images of patients in a panel that have already fulfilled that measure for the year. Or it's looking at provider dashboards to look at things such as the number of visits a provider has seen, a number of appointments that a provider has fulfilled. So there's things like that that do exist that I wish that more organizations got to. But I proudly say that this is what we do at Nautical Health. We're an implementation consultant firm. We do not strategize. We do not take $1 million to build PowerPoints. We build the organization. We give them the tools to build these types of reports so that they can actually see what they're doing well. Similarly, on the work side, we make sure they select the right health IT. We build their workflows for them with their team, and then we train them on how to effectively use technology so that you can be in compliant and you're not skating in areas where it could be risky to someone's license or risky to someone's patient.
So you mean you are standardizing the data in the Nautical, standardizing the data instead of giving a new system? This is the way you are working by the consultation?
Well, it's a combination of both. So standardized is
Both.
always good to do first, and you want to use the standardized tools first. But it starts to give the organization a preview of their performance and how they're doing. At some point, whenever you start to build a bunch of standardized reports, the next step is going to be, okay, well, this is how we compare to our peers, but we have some unique process in our organization. So we have some unique ideas. And so because of that, we need reports that's going to tell us exactly how we're doing these very unique things in our hospital. And that is when the customizations come in. But you always have to have some type of standards that's going to help guide that decision making.
Clear, clear. Another question regarding from me also in regard of the repository. Was it better to build one national repository or connecting multiple existing one?
That's a really good
Because we are
question.
trying to unify the system, but it's hard also.
That's a really good question. And the answer is in what organization is asking the question. So if the Ministry of Health from Saudi Arabia asked me that question, I would say one system, one very system that has a propensity to bring in every type of health data known to man inside of the Kingdom of Saudi Arabia. And it is clearly organized. And through that one system, you have standardized reports that you should be able to give out to every single primary care group, every single hospital, and even chop those reports up to where they can be given out to every single provider. So that's my answer if I was talking about uh, health for a country. Now, as we start to talk about hospitals or we're talking about clusters inside of the government, or we're about a large pharmacy group, that conversation changes a bit. And one of the reasons that it changes is because there's different privacies and different levels that you may have to the data. So, for example, old EHR data from an old system that you used to use should probably live in a repository on its own because you want to use that data only when you're going into the charts of a patient that you have to pull that information back. But let's just say that hospital gets shared pharmacy data from some of the major pharmacies, and you want to know how frequently patients are filling their prescription. It wouldn't be wise to mix that with data because the data is not really related to each other. So keeping data in a separate repository is going to be easier to extract and easier to keep clean as well as to keep it protected.
Anyone have any question? No one. But I have also another question, Sir Robert.
Okay, no problem.
If you know our system here, we have two digital platforms as electronic health record, one from the Ministry of Health and one from the Ministry of Defense for Health Services. Both are made from a company named Lean. But the integration of system how could we overlap the repetitive of care and ensure a seamless patient journey when individuals move between different sectors? Both systems are providing the same info, the same information, but from Ministry of Health to Ministry of Defense, someone is not trusting the other, so they are repeating everything, the imaging, so is this can we overcome this, or this is related to the different sectors? Them, if you are facing the same issue with because repetiting of care, wasting the unifying of system.
So I think this is a really good question. And the United States actually has dealt with that, where there's a private healthcare system that runs primarily on health plans, and then you have the VA as well as the military hospitals that are ran in a totally separate entity. And to be very specific, when you are active duty military in the United States, that is a different healthcare entry point from when you're actually a veteran. So really, it's three different systems in the U.S. Now, the truth is this: there are commonalities that I believe exist between a military entity and the private civilian healthcare entity. What I believe the true solution is creating a single source data repository that only houses recent information. So it basically is the patient information for like the last year. And that's where the images go and all of that. And I think what should happen is that you should be able to go in and clear to get any of that most recent information and then pull that information over. So basically, I think it should be a single source repository that has three dimension connections from each entity that's going to be connected to it. And then you just simply go in and you pull that information that's most relevant. Now, that's easier said than done. Some people that becomes more of a political question of whether or not the line should cross. But you're right. Many do feel that they have to repeat services. It does create stagnation and it does become expensive. But as the media in particular are starting to think about the integration of these large data repositories and thinking about migration, as long as you can build more policies and more standards around the use of health technology, I get answers a lot of these questions. It's better to plan and then get a strategy for how you're going to use it and implement it, rather than to think about the problem without there actually being a piece of legislation that guides that decision.
Yeah. I have a last question for you, Sir
Okay.
Robert. Do you have any experience working here in Saudi Arabia from any region in the MENA?
Yes, I do. I'm really proud to share that I'm doing what the Nautical Health is doing work not only in Qatar, but we're also in partnership with the Eastern Cluster. So we are developing a pilot. We're also doing some work in Bahrain, as well as we are a remote patient monitoring company that's based locally in the Kingdom of Saudi Arabia, as well as we're working with several different health IT companies throughout the Middle East as well. So a lot of movement currently in the Middle East. And we're really excited about it because it's new and it's fresh. And we also believe that the Middle East is a lot more receptive to thinking in terms of implementation and not just high level policies, but what happens when the policy is, we got to actually do the work. We have to build the dashboards. We have to create workflows. We actually have to make sure that the clinicians are trained properly. And that's the piece of it that I get really about.
Yeah, thank you. Anyone have any question? I see no notes in the chat. Now I think we can end our session, Sir Robert. Thank you very much for the excellent and insightful session.
Okay.
Thank you for all the participants. Yes, you can say.
Oh, I was just going to say our last session is on care pathways. That will be on May the 4th. So it's coming up, and that'll be the last one. And then afterwards, we'll work with the team to get everybody certificates. The recording of this session will go out, as well as we will make sure that individuals receive a version of this PowerPoint. Also, just wanted to highlight quickly for those individuals that are very interested in health IT and what's going, a couple roles that you can consider. One is a clinical advisor, a practice transformation specialist, a health IT consultant, or becoming a project manager. So we look forward to talking to you all again. I'll leave up our contact information in case you want to get in contact with us. And if not anything, talk soon.
Thank you. Appreciate it, Robert. Have a good and wonderful day for all of you.
Thank you. Bye bye.